All right, we're doing IEA pathology questions. Let's get started. Um, as always, the ones I get wrong, I put a star sign next to them, and I'll say why, like what kind of tricked me. So, 45-year-old man comes to the physician because of progressive difficulty breathing in hoarseness. Physical exam shows oval-shaped rubber mass. So, some sort of mass around the thyroid, around the neck that causes problems with breathing and interfering with the nerves. And the mass has reduced radioactive ion uptake. Um, Biopsy shows no mitotic figures. That means the cells aren't dividing. That means uh, just means they're not dividing. Which of the following morphological feature most likely seen in this patient? So it's the differentiated follicular cells, right? So that's reminding me. The fact that they're not mitotic is kind of suggesting to me that it's kind of like a benign thing, and that to me sounds like something with uh, intact capsule, right? And the follicular cell sounds like a follicular adenoma of the thyroid, right? Which can, so follicular adenoma is from the thyroid, right? It has this capsule around it. And in this capsule, there are these like kind of like cells that are it's like a hyperplasia situation. And if this capsule breaks, it goes from follicular adenoma to follicular carcinoma, uh, which is one of the four types of thyroid cancers we have. So, next question. I'm gonna time myself. 37-year-old woman comes to a physician because she's gaining weight. What she's eating as she was before. Uh, there's ascites and there's cloudy fluid in a paracentesis. So they take the fluid out. It's cloudy. It stains positive for PAS. PAS it stains glycogen and mucus stuff. So there's like mucusy stuff in the peritoneum. Abdominal ultrasound shows a cystic mass on bilateral at nexal. At nexal means next to the uterus. So there's bilateral at next. There's a cystic mass there. So it's already making me think of like a tumor on the ovaries that has kind of like a mucinous or like some sort of surface epithelial tumor of the ovary is what's making me think of. Uh, but the fact that they're bilateral, that means there's a chance that it's metastasized from the stomach, something like that. So that's also the back of my mind. The masses are surgically removed, and there's single cells. So single cells are histologically they're identificators of the diffuse type of cancer, which is this type of stomach cancer that can metastasize to the ovaries via seeding, right? It's not hematogenous. It's not through lymph. It's seeding. It's through the peritoneum. That's why it's in the stomach and it makes its way to ovaries because they're all connected to the peritoneum. And one thing you'll see is that it kind of happened in a younger woman, first of all, because the primary tumors of ovary happen in more like the older adults, uh, but it also happened to be bilateral. So it's asking what's kind of like the gene mutation that's characterized by this. The answer is E-cadherin. Remember, E-cadherin are they're like these are cells. They're like the proteins that connect cells to each other, right? And there's a mutation in there, it means the cancer can metastasize easily or more easily. And two things that I can think of, one of them is this, the other one is lobular cancer or lobular carcinoma of the breast that also has a E-cadherin deficiency. And remember that for that one, when we get the lobular carcinoma of the breast, the cells are like in a column. And remember, these cells are supposed to like be in a circle. So you can think of, there is a problem with the proteins that they're connecting these cells together. That's why they don't look like they're standard, like circular or like shape that they make a lumen. They kind of look like they're in a column. Okay, should be right. But this one I got wrong. I'll tell you why. It was a stupid reason. 26-year-old uh, hasn't had periods for over 2 years. Um, acanthosis, which is like black. The skin is getting velvety black armpits and posterior neck. It's usually indicator of like some hormonal problems, some metabolic problems, sometimes heart problems. She's got hirsutism and a BMI of 30, right? So it's kind of like making me already of a PCOS kind of vignette. Pelvic ultrasound shows multiple cysts, right? So multiple cysts, hirsutism, high BMI, this acanthosis thing, all of them are PCOS. So in PCOS, what you have is basically you have high LH, right? And that causes high androgens. And you also happen to have a high BMI, which means like high fat. You have a lot of fat already, right? Fat tissue changes androgens to estrogens or estrogenic compounds. And these guys, so these will give us the hirsutism and stuff like that. And then this give us, um, it gives us the follicles, and it messes up with the period. It kind of what else? I mean, just the multiple cysts is as a result of estrogen because you're never getting that the second phase of the cycle. So the if you remember the follicular cycle, the first phase this is like where ovulation is, right, and this is the second phase. So um, this is estrogen. Uh, this is progesterone dominant. This is where ovulation happens, right, and this is where menses happens. So these gals they stay in this phase longer than usual. That's why they have longer periods. So this phase is always around like 14 days. Once ovulation happens, like this goes on. So when they say, "Oh, this person has had a like period in like their period takes like 50 days," that just means the first phase is longer, and that's an indicative of a hyperestrogen like state, right? So the answer to this question is high estrogen, which is um, basically indicator of an indicator for PCOS. So what the mistake I made is I chose this, but in fact, what we're looking at is a high like LH to FSH. We want it to be high, right? Not the other way around. So LH is what goes up, and FSH is I don't think it's changed in PCOS B. So as you notice, like I got way more questions wrong from the IEA questions compared to the SNL ones. I think these questions are harder, and I also think there is sometimes stupid questions here, and I'm gonna point that out when I get to them. So, um, so we've had like 4 questions in 6 minutes, not bad. 35-year-old woman, palpitation and unintentional weight loss. So maybe it's a hyperthyroidism question. No heart problems. She's losing weight, but diet isn't changed. Kind of high blood pressure, high pulse, temperature is okay. Um, doesn't use any drug. There's wet skin, thinning hair, and absence of a neck mass. Right. Ultrasound of thyroid shows no abnormalities with and radioiodine studies show decreased uptake of thyroid gland. Right. So it's kind of making me raise my eyebrows a little. Uh, so high we have high T4 but low TSH, and ultrasound. I remember this question. It's a hard question. So basically, what we have is that we have high T4, right, low TSH. So that just indicates something is secreting thyroid hormone, and our symptoms are kind of consistent with this. Like we got low weight, high blood pressure, like heart is beating harder, and then you're like moist and wet skin. All of this is kind of like sympathetic like thyroid like responses, but then there is no mass, right? So the question is basically asking you, you have ectopic thyroid hormone secretion. Where is it coming from? The answer is ovary. um, the ovary can sometimes have tumors. These teratomas. Remember, these teratomas can have like normal human tissue. Sometimes they can have thyroid tissue in them, and they will be producing thyroid hormone. So this was a hard question because I was just reading this, not even thinking of like metastasis, like what kind of a thyroid disease. I think I chose thyroid maybe for this question. I don't really know. All right. So 26-year-old woman hasn't had a period. Again, this is kind of a PCOS situation. Hasn't had period, hirsutism, high BMI. The question this time tells us there's high estrogen and androgens. The question also tells us there is cysts in the left and right adnexal hole, which is where the ovaries are supposed to be. Which are following is a complication of this condition, right? Endometrial hyperplasia. All right, so I recall our conversations a few moments ago is that estrogen is the main thing that goes up, right, in PCOS. Okay, so uh, what does that cause? One of the things it causes endometrial hyperplasia. Estrogen is remember estrogen therapy increases chance for endometrial cancer. So if you're secreting it as like part of a pathology like PCOS, you're also causing endometrial hyperplasia. But let's look at the other ones. Hypoglycemia is wrong. You get hyperglycemia, and it's kind of like ties in together with the high BMI and like kind of pre-diabetic, diabetic, type 2 diabetes, all that PCOS ties in really well. There's a strong association between PCOS and diabetes type 2. Uh, luteal cysts. So this luteal cyst, oh, luteal cyst is basically happens. So sometimes you'll have tumors that uh, secrete beta HCG, right? And these beta HCGs, if the tumor, like let's say when you're pregnant, it's supposed to be at a certain level, like let's say like level 100, but then the tumor is secreting at a level 10,000. That stimulates the ovary to do funny stuff, and like over stimulates the ovary basically. And one of the things it does is that it makes a luteal cyst. That's what I think a luteal cyst is. Ovarian epithelial tumor. High estrogen isn't really a risk factor of ovarian epithelial tumor, at least not that I can think of. High estrogen, really, what it makes me think of is endometrial hyperplasia and germline tumors. A, so it's our answer, yeah. So this one I got wrong too. 60-year-old, there's a mass on the right breast for the past 12 months. It's firm and non-tender. Non-tender makes me think of like kind of a malignant thing, at least not an infection. There's no overlying skin changes, nipple retraction, or axial lymph adenopathy, so no visible abnormalities. Fine needle biopsy of microscopic examination shows cellular stroma with surface what? With surface. Okay, it's a weird description of what it looks like. Uh, the stromals. Okay, so mild atypia is seen on biopsy and no overgrowth, which are following complications most likely associated with this condition. Okay. Oh, I get that description now. So here it says slit and cleft protruding into spaces. I mean, protruding into spaces. Like, so basically, some tumors, like if this is a tumor, some grow like this, but some like, like, like make things that kind of like like invades. It's not really invasion, but it's like it goes into the stuff around them, right? So one of the tumors that does that is this type of fibroma. I don't know how to pronounce it. Has it? Let's see. Um, it's phyllodes tumor, right? So this tumor, it kind of does that. And one thing to know about, a couple of things to know about it. First of all, it's kind of like made from fibrous tissues. Second thing to know about it is that it has these protrusions, right? It has the potential to go malignant. It happens in older women, right? Uh, yeah, and it's got that weird name. Now let's see what this question is asking us. So metastasis to the axilla and lymph nodes. Um, it can go malignant, but metastasis is not the first thing I would think of. One other thing about these tumors in general that have like a lot of um, like spikes and stuff that invades into the tissue next to them is that when a surgeon wants to like cut this off, there's always going to be like they're going to reject something like this. There's sometimes going to be some stuff left here and here and here, so you're at risk of having a recurrence, right? So recurrence after resection is uh, even though mammalian transformation is possible, but this is also you get recurrence, and that's kind of the same case with polymorphic adenoma uh, of like the parietal glands. Same story. You get recurrence because you have those kind of like invasions into the tissue around you. Yeah, B. So 56-year-old comes to a physician because of vaginal bleeding for the past 4 years. He has menstrual period 6 years and okay, so 56-year-old has lost 3 kilograms over the past month. There's a mass on the right ovary. Uh, which one of them does the biopsy will show? And she's got bleeding for the past 4 weeks, right? Uh, so it's kind of older lady. So we're not expecting any germline tumors, right? That's more of a reproductive age. Germline, remember, okay, so you're producing gametes. So I mean, you're technically not producing gametes, but the way you can remember it is that if a woman is in reproductive age, they have a lot of their germ lines which produce the ovums. Those are active, so you will have at a higher chance of developing germline tumors, right? So germline tumors is not really something that older women get. So A is a description of a teratoma. A is not it, right? Rankin crystals. So this is the Ranki crystals is for Leydig cell tumors, right? Leydig cell tumors is for it usually happens in men. It produces testosterone, but it can also happen in women. But you would see signs of hirsutism, right? So it's not either large uniform round cells with lymphocytic invasion. I don't know what this is referring to exactly. Single ring cells. This is the diffuse adenocarcinoma of the stomach, and it gives you a bilateral ovarian metastasis, right, through seeding. Um, and one thing we missed that I just saw is that there is thickened endometrium, right? So we have two things we're not supposed to see in this girl. One of them is that she's bleeding, she's not supposed to be, right? And there's thickened endometrium. Thickened endometrium, as always, is it clues us into what? Clues us into estrogen production. So we're looking for a tumor that produces estrogen. And the granulosa tumors is one of the things that produces estrogen, just like how granulosa cells do, and they have these called Exner's bodies. And the way I think First Aid or one of the resources has a mnemonic for it is like call your granny as in granulosa cells and X. So call your granny and X, and that's how I remember it. E. Right. 16 minutes. I started my timer a little late, so okay. 50-year-old woman comes to the physician because of 5-year history of red scaly patchy skin on the breast. Okay, so there's some cutaneous changes. Uh, she used a typical topical cream. It doesn't work on physical examination. There's like some eczema. Okay, there's large cells with hyperchromatic nucleus and perinuclear halos, right? So two things important here. We have some skin changes. It's kind of like red patchy stuff around the nipple, and we have some abnormal looking cells. I don't really know what abnormal is exactly, but large cells. So they're like larger than normal. That's not normal. Hyperchromatic nucleus. The nucleus are hyperchromatic, which is they're darker than normal. That's and then there's perinuclear halo. What I'm thinking is that if it's not normal, if it was normal, they would just not say it. They would just say like whatever normal. So some abnormal looking cells, and you have these cutaneous changes. So this is a Paget's disease of the breast. Basically, when you have this breast, right. This is a nipple. Let's say this is a breast. So there's these like all these like. Uh, this is like the ducts that produce milk, and this is the nipple, right? So if there is a cancer within these ducts, and like the ducts end at lobules, these lobules actually produce the milk. These ducts just take them to the nipple, right? So if there is like cancer of these ducts, these cells are squamous, right? They can just like kind of like keep reproducing until they come to the nipple, and when they come to the nipple, they'll like it's the same, like it's all connected to the actual like skin, right? So these cells kind of, so you'll have skin with like malignant cells like interspaced with them, and that's called patient's disease of the nipple. Now in the vulva, the same type of thing can happen, but the difference is in the vulva we don't have like a population of pre-malignant or malignant cells, uh, that, or we don't have cancer in vulva that's like presenting as this. So it's high yield to know that Paget's disease of vulva or extramammillary Paget's disease is not connected to an underlying cancer, while uh, mammillary Paget's disease is connected to an underlying cancer, and that cancer specifically is ductal carcinoma in situ, right? Because it's from ducts, it's carcinoma, and it's in situ because it hasn't gone, like it hasn't invaded through these ducts yet, right? Right. E. Okay. So this one I got wrong first. Let's see if I remember why. It has a question mark too, which means I didn't really like the question. Oh, I remember it. 56-year-old woman comes to the physician because of vaginal bleeding for the past 4 weeks. Okay, 56-year-old, some vaginal bleeding, um, progressive fatigue, weight loss, unintentional, past 3 months. So we kind of got a cancer vignette, sounds like. Vital signs are within normal limits. Pelvic ultrasound shows a thickened endometrium, right? Thickened endometrium and a mass on the right ovary. Basically, aka, there's a mass on the right ovary. It's producing estrogen, right? And the estrogen is hitting our endometrium, which I always draw like this, and it's like causing hyperplasia of endometrium, right? And this is the ovary. So, what is a complication if it remains untreated? So, a couple of things can happen here, right? First of all, you have a mass here. When you have a mass on the ovary, you're susceptible to ovarian torsion, which is having this ovary like rotate around itself because it has a mass on it, and that kind of like, because the blood supply of the ovary comes through um, these ligaments, these tendons or whatever here, uh, and these tendons, not ligaments, these tendons, and if it twists around itself, it kind of closes that off, and kind of you get like pain, and it's called ovarian torsion. So that's something that has a you have a risk factor for. But uniquely, we have thickened endometrium, and I think like that's maybe like what's to clue you into what the question is looking for, is that because of the high estrogen, we have an increased risk of endometrial carcinoma, right? But the reason I didn't like this question is because I thought torsion is also a quick an answer. All right. My favorite type of questions. No, actually, it's not. I thought it's a congenital adrenal hyperplasia, but it's not. So, 25-year-old Asian woman, has a little bit of high blood pressure. She's has positive for beta HCG. So you think, oh, maybe she's pregnant or some, or has a type of a tumor. And they also tell you that there's a snowstorm appearance with no fetal tissue, right? Or heart detected. Dilation and cortage shows trophoblastic proliferations with edematous villi, right? So what does that make you think of? You should be like, I mean, for me, when I saw storm appearance, I already knew that that was associated with hydration moles, right? So these are basically kind of like results of conception that they haven't formed properly. So it can be a partial or like a complete, and the complete one, has higher beta HCG. They both do, but have this one just has only high beta HCG. So complete one has more. I just know the complete one has, this is kind of like the more aggressive one. It has a more chance for transformation to uh, choriocarcinoma. So, and it also has a higher chance for just general invasion. it also like this one does all the bad stuff. This also, makes your like grows your uterus. So it's like they describe it as like, oh, the uterus is bigger than what you would think of based on the time of the conception. So what else? Oh, this one, the partial one, has partial baby parts, right? This one doesn't have in this question, so this one is more likely a complete one. But yeah, so basically, the way you differentiate them is, this one has partial baby. The partial mole has partial baby parts, like parts of babies, uh, or not babies, fetuses. The complete one has snowstorm appearance, and higher chance of transformation to choriocarcinoma and invasion in general. And remember that these choriocarcinomas, they so they're like primitive tissue, right? They're good at, and what are they coming from? They're coming from placenta. What is placenta good at? It's good at getting stuck to the endometrium and kind of invading it. So these guys are really, really good at invading and like spreading apart. So choriocarcinomas are really good at hematogenously metastasizing to the lung and kind of like taking over all the lung. And they respond really well to methotrexate. That's another point to know. So in this case, so we know it's a complete one, and the complete ones have 46 chromosomes, like they have the normal chromosomes. The partial ones have 69, right? And it's 23 times 3. So they have, three copies, and they're all coming from the father. This is also, they have two, but they're all coming from the father. So it's always the dad's fault in this scenario. So um, we're looking for something that has 46 chromosomes. C is the only one with that. So as you can see, I got a lot of them wrong first try. So 62-year-old uh, comes, there's like weight loss, constipation past 3 months, no appetite changes. She always feels full. Uh, Again, weight loss, distended abdomen. There's a palpable non-tender mass on the right and left pelvic regions. The pelvis ultrasound shows a bilateral adnexal mass and heterogeneous cystic spaces. Which of the okay? So we're like thinking of like the cystic spaces, and it's like bilateral is on the ovaries. Okay, so we get an idea. Let's just start reading. Serous carcinoma and mucinous carcinoma. Actually, these two were the things I was thinking of. It could be teratomas. It can't be because it's usually unilateral. These are all unilateral, right? So the only thing that can really be bilateral is these guys, and metastasis. Again, like I've said this like 50 times, metastasis from the stomach, from the diffuse type of cancer of the stomach into the ovaries. That one has single cells, right? Here we don't have single cells. So here I think I'm gonna go with the more common one. Uh, I'm gonna go with, we don't have description of mucin. If we had like, oh, it's also PAS positive, something like that, then I would go with the mucinous. But serous one is more common. I'm gonna go with the serous one. And I'm wrong. Yeah, let's see. Uh, let's see what the explanation says. I think basically what it says, maybe the serious one is in the more common one, maybe the mucinous one is the more common one. I didn't really like this question, to be honest with you. Oh yeah, I marked it wrong. It is serious. Ignore this. Right. But the reason is that it's more common basically. Okay, so we had our part one. Part two will be in the same playlist. So I'm gonna pause this one.